Usually when we think about surgery, we picture something um, incredibly precise, almost isolated, right?
Right, yeah, like a localized intervention.
Exactly. It feels like engineering. Like
Yeah.
you have a ruptured appendix, the surgeon goes in, removes the bad part, sews you up, and the rest of your body is basically just a spectator.
A spectator, yeah. A
Uh,
single targeted strike where the systemic impact is, well, it's usually pretty minimal.
but when you step into the world of severe burn injuries, that entire paradigm just goes right out the window.
Oh,
I
entirely.
mean, we are no longer looking at an isolated event. We're looking at a massive, systemic, full-body crisis.
You're treating the whole system.
Right. So today, we're unpacking the intense, really high-stakes choreography of burn surgery. And we're tailoring this deep dive specifically for those of you preparing for board exams like the FRCS and plastic surgery.
Which is a tough exam, so paying attention to the physiology here is key.
Absolutely. Your mission today is to understand how we balance time, blood loss, and these wild cutting-edge materials to save lives and physically rebuild the human body. We're looking at clinical medical notes and surgical guidelines to really get into the weeds here.
And what's crucial to grasp right off the bat is that burn surgery isn't just about, physically removing damaged tissue.
Right.
It's fundamentally about managing a catastrophic physiological response to trauma. Every single cut you make, every dressing you apply, it's a calculated move to control a biological system that is just an absolute overdrive.
Yeah, and we're going to explore some really fascinating stuff today.
Yeah.
Everything from why you actually want a wound to bleed during excision.
Which sounds so counterintuitive.
It really does. To how, like, shark cartilage and the sandwich technique are used to literally restore human skin.
It's incredible science.
It is. So let's jump right into the first clinical problem, which is the clock. Because before you even pick up a scalpel to excise a burn, you have to decide when to operate.
Timing is everything. It dictates the entire physiological outcome for the patient.
So let's start with the absolute immediate emergencies. Like the second a severe burn patient rolls through the doors, what's step one?
Well, the immediate life threats have to be neutralized before you even look at the skin for grafting.
We're talking ABCs.
Exactly.
Yeah.
So if there's an inhalation injury, that means securing the airway, usually with an emergency tracheostomy.
Or getting that tube in.
But just as urgently, you have to look at surgical decompression. Severe burns cause massive tissue edema,
Swelling.
profound swelling. And if that happens underneath tight, unyielding burn skin, what we call the Escher, especially circumferentially around a limb or the chest,
It basically acts like a tourniquet.
a literal tourniquet, yeah. It cuts off arterial blood supply to the limbs, or it physically restricts the chest from expanding so they can't breathe.
Wow.
So you have to perform escharotomies to decompress those compartments immediately. You just slice through that tight Escher to let the tissue expand.
Okay, so the airway's secure, compartments are decompressed. Now we look at the burns themselves. We have an option of what the guidelines call immediate excision.
Right, operating within that first 24-hour window.
Yeah, taking the patient to the OR to surgically remove deep burns and graft them right away. What is the fundamental physiological benefit of moving that fast? I mean, they just went through a massive trauma.
It's a great question. To understand the benefit, you really have to understand the hypermetabolic response.
Okay.
A large burn triggers this massive release of catecholamines and inflammatory mediators. The body just resets its core temperature.
So they run super hot.
Right. Cardiovascular output skyrockets, and the patient enters a severe catabolic state. They're essentially consuming their own muscle and fat for fuel just to survive the trauma.
That sounds exhausting for the body.
It is. It's devastating. So by performing an immediate excision, you are physically cutting away the dead necrotic tissue that is driving that massive inflammatory cascade.
Oh, I see. You're removing the fuel for the fire?
Exactly. You significantly blunt that hypermetabolic response. Plus, specifically in pediatric patients, operating within that first 24 hours is actually associated with significantly less blood loss compared to waiting.
Wait, really? Less blood loss?
Yeah, the microvascular changes haven't fully set in yet.
That's fascinating. But the logistics of that sound, frankly, terrifying. Doing a massive excision within 24 hours means operating on a patient who is still in systemic shock.
Oh, it is an immense physiological hit. And it's incredibly resource intensive. You can't just have one surgeon poking around.
Right.
You need multiple surgical teams working simultaneously to minimize the time the patient is on the table. You need a massive guaranteed supply of blood products, assured ICU facilities.
So you really need a specialized burn center.
Absolutely. Because the surgery itself inflicts such a massive secondary trauma, immediate excision is often entirely inappropriate for elderly patients. Or, those with major comorbidities who simply aren't physiologically fit enough to survive the operation itself.
Which naturally leads us to the staged alternative, right? Early serial excision.
Right, the sub 72-hour window.
So if the patient can't handle the massive immediate surgery, we do it in stages within the first 3 days. We excise up to, 25% of the total body surface area, or TBSA, at a time?
Usually about 20 to 25%, yes, spacing the surgeries out every 48 hours.
And the rationale there is just letting them recover in between.
Exactly. By waiting for that initial fluid resuscitation to complete, you allow the patient's hemodynamics to stabilize. This staged approach focuses on volume reduction.
Meaning you target the biggest areas first.
Yeah, taking out large confluent areas like the back or the trunk first, you inflict much less of a physiological insult on the patient in any single session.
But leaving some of that necrotic tissue on the body for days, that has to have a major downside. Are we just prolonging the exact hypermetabolic response we were just trying to stop?
We absolutely are. It's a compromise. It prolongs the hypermetabolism, and it leaves the door wide open for infection.
Because you have dead tissue just sitting there.
Right. And repeated trips to the operating theater significantly increase the incidence of bacteremia, bacteria basically seeding into the bloodstream during the manipulation.
Right.
Plus, if the patient becomes medically unstable between these staged surgeries, you have to abort the plan.
Oh, wow. So what happens to the burn?
The remaining unexcised deep burn simply has to be left in situ. You manage it with topical antibacterial agents until the patient recovers enough to go back under the knife.
Okay, so that's the immediate and early window. Now let's look at the intermediate timing, which is this really fascinating clinical gray area.
The 10 to 14-day window.
Yeah. This is for indeterminate depth burns, where it's not totally clear if the burn is superficial partial thickness or deep partial thickness.
Right, you're just not sure yet.
And the conservative approach here is to wait 10 to 14 days. And, this actually reminds me of pruning a severely frostbitten houseplant.
Oh, interesting. How so?
Well, instead of hacking away at the stems immediately when they look bad, you wait a couple of weeks to see which leaves naturally bounce back and which ones are truly dead. That way, you don't accidentally remove a branch that would have recovered perfectly on its own.
That analogy holds up perfectly, actually, and here's why. If you hack at that plant too early, you aren't just removing dead leaves, you might be cutting off viable nodes that were preparing to sprout.
Right.
In the skin, early excision of a mixed depth burn might actually worsen the final outcome.
Because you're taking healthy tissue.
Because you run the very real risk of surgically removing epidermal appendages, things like hair follicles and sweat glands deep in the dermis.
Oh, and those are what help it heal.
Exactly. Those would have allowed the wound to naturally reepithelialize and heal completely scar-free if you just left them alone.
Okay, so what exactly happens at that 10 to 14-day reassessment point? Why is that specific time frame the magic window?
Because at that 10 to 14-day mark, you have to make a definitive clinical prediction. Will this wound completely heal within 3 weeks of the original injury?
3 weeks is the cutoff.
That 3-week mark is the absolute biological finish line. Burn wounds that heal in under 3 weeks generally do so without forming a scar.
And if your clinical judgment tells you, hey, this is going to take longer than 3 weeks,
then you immediately treat it as a deep burn. You excise it and you skin graft it.
you don't wait to see if it heals in week 4 or 5.
No, because if you simply allow an indeterminate burn to heal conservatively for more than 21 days, 78% of those wounds will go on to form thick, rigid, hypertrophic scars.
Wow, 78%. That's a huge jump.
It's massive, so it requires profound clinical judgment. You have to balance the patience of conservative management against the strict biological clock of hypertrophic scarring.
Okay, so we figured out exactly when to cut. But the next hurdle for these residents to understand is figuring out exactly what we're cutting away.
Right, the actual excision technique.
Yeah, we are physically shaving away the dead tissue.
Yeah.
But how do you know where the dead tissue ends and the healthy tissue begins? Let's break down tangential excision.
So tangential excision involves using a guarded skin graft knife. You repeatedly shave the burn eschar in very thin sequential layers.
Just shaving it down.
Yeah, you are paring it down millimeter by millimeter until you hit a viable wound bed. And the visual cues are everything here.
What are we looking for?
Viable, healthy dermis is white and glistening. If you go deeper, healthy subcutaneous fat is uniformly yellow.
But inadequate excision, meaning you haven't cut deep enough and you're still in necrotic tissue, that presents entirely different visual cues, right?
Completely
You
different.
see, like a dull yellow-gray dermis, pink-brown blood-stained fat, and thrombosed blood vessels.
Exactly.
Now, here is the paradox we teased earlier. One of the primary definitive indicators that you have finally hit healthy tissue is that the wound bed starts bleeding.
Yes, briskly.
It's like peeling an onion down to its fresh layers to find where the sap is still slowing. But we are intentionally causing massive blood loss in a trauma patient who is already hemodynamically unstable. That sounds crazy.
It is the ultimate tightrope walk of burn surgery. Blood loss is absolutely the enemy, but brisk, punctate bleeding is the only true real-time indicator of tissue viability.
Because if it doesn't bleed,
If it doesn't bleed, the microvasculature is dead. And if you place a skin graft onto a dead wound bed, the graft will inevitably fail.
so you have no choice.
None. You are forced to induce immense blood loss just to ensure the tissue is alive enough to accept the graft.
Which explains why in certain catastrophic cases, we just abandon that delicate shaving method entirely and go straight for a fascial excision,
Right.
where you cut all the way down, entirely bypassing the subcutaneous fat straight to the deep fascia.
Precisely. Fascial excision is generally reserved for massive, life-threatening burns, especially in areas like the trunk where you obviously can't apply a tourniquet.
Right, so you use cutting diathermy.
Yes, to minimize blood loss. You're cauterizing perforating vessels as you go. The major advantage is a massive reduction in bleeding and absolute, undeniable certainty regarding the viability of the wound bed. Fascia has an excellent blood supply.
But the trade-offs are brutal.
Oh, they are terrible.
It creates these awful cosmetic contour defects because you've removed all the underlying fat,
Yes.
and it carries a severe risk of cutaneous denervation, basically leaving the area totally numb. Plus, you risk exposing structures like bone or tendon, which, and correct me if I'm wrong, will not accept a standard skin graft.
You're completely right. They won't take a graft, and it gets worse. If you perform a fascial excision circumferentially around a limb, you disrupt the lymphatic drainage so severely that it causes permanent, debilitating distal edema.
So their hand or foot just swells permanently.
Exactly. It is strictly a salvage procedure.
Okay, so since tangential excision is preferred, we have to talk about how to manage that massive bleeding it causes. Because the risks of massive blood transfusions aren't just logistical, right? They are highly toxic to the patient.
Very toxic.
We are talking about severe complications like TRALI transfusion-related acute lung injury.
TRALI is a terrifying complication. It occurs when antibodies in the donor plasma react with the patient's white blood cells, specifically the neutrophils, within the pulmonary capillaries.
So it's an immune reaction in the lungs.
A massive one. It damages the vascular endothelium in the lungs, causing fluid to leak rapidly into the alveolar spaces. The patient essentially drowns in their own pulmonary edema.
Good God. And massive transfusions also cause severe hyperkalemia, right? Dangerously high potassium levels.
Yes, and that mechanism is important to understand.
Right, because when red blood cells are stored in bags, their sodium-potassium pumps slowly fail over time, so potassium naturally leaks out of the cells and just accumulates in the preservation fluid.
Spot on.
So when you rapidly infuse units of stored blood into a patient, you are basically injecting a massive, concentrated load of potassium directly into their bloodstream.
Which can trigger lethal cardiac arrhythmias. And if you add to that the dilution of coagulation factors from all those fluids, the patient loses their ability to form clots entirely.
It's a vicious cycle, which is why we rely on a heavy arsenal of chemical and surgical strategies to avoid transfusions in the first place.
Before we even cut, we use tumescent infiltration.
Injecting fluid, right?
Yeah, we inject the subcutaneous space with a massive volume of fluid containing epinephrine diluted to like 1 in 1 million. Epinephrine binds to alpha-1 receptors in the blood vessels, causing profound local vasoconstriction.
So you clamp down the pipes before you cut them.
Exactly. We also practice permissive hypotension, intentionally keeping the patient's systemic blood pressure on the lower end of normal to reduce bleeding pressure.
And we also use systemic drugs like terlipressin, which is a vasopressin analog that constricts the splanchnic circulation, and recombinant factor, VA Novo 7, to jumpstart the coagulation cascade.
All trying to get the body to clot.
Right. And then there are topical sealants applied directly to the wound bed, like Tesil. Now, Tesil contains human fibrinogen, thrombin, and bovine iproteinin. To me, it sounds less like a traditional glue and more like we're chemically tricking the body into thinking it has already formed a massive scab.
That is the exact mechanism. You are bypassing the entire early clotting cascade. The thrombin in the sealant immediately converts the human fibrinogen into a stable fibrin clot right there on the wound bed.
Instant scab.
Yeah. And the bovine aproteinin is an antifibrinolytic. It prevents the body's enzymes from prematurely breaking that newly formed clot down. You achieve rapid hemostasis without relying on the patient's depleted systemic coagulation factors.
Okay, so the bleeding is controlled, the
Yeah.
dead tissue is gone. But in solving that problem, we've created a new, equally terrifying issue. The patient now has massive, entirely exposed raw wounds.
Right.
Autografts, the patient's own skin, are the gold standard for coverage. But if a patient has deep burns over 35 to 40% of their body, they simply don't have enough healthy donor skin to go around. So how do we buy time?
When autograft isn't available, we desperately need temporary wound closures to stop the patient from decompensating.
What's the first line of defense?
Usually organic biological dressings,
Mm-hmm.
primarily cadaveric allografts. Now, fresh, live unrelated allografts from organ donors revascularize beautifully, but in many regions, they simply aren't available due to logistical or regulatory constraints.
You just can't get them.
Right. So we rely on banked cadaveric skin that is either freeze-dried and stored in high-concentration glycerol, or it's cryopreserved at negative 80 degrees Celsius.
Is there a functional difference between applying the glycerol-preserved skin versus the cryopreserved skin?
A significant one, actually. Glycerol-preserved skin is effectively dead. The cells are no longer viable,
Okay.
which means it has a longer shelf life and triggers a relatively mild immune response. Cryopreserved skin, however, still contains viable donor cells.
Oh, they survive the freezing.
They do. And while it functions incredibly well as a physiological cover, those live donor cells will eventually trigger a potent local cell-mediated immune rejection in the patient.
So it buys you time, but you know it's going to be rejected.
Exactly.
And I know in low-resource environments, we also see the use of human amnion, which is cheap and readily available, or porcine xenograft, which is pig skin.
Yes.
But porcine skin doesn't revascularize at all, meaning it has to be rigorously replaced every few days to avoid severe subgraft infection.
Right, it's very temporary.
What I find truly ingenious, though, is the Alexander technique, colloquially known as the sandwich technique.
Oh, the sandwich technique is a masterclass in stretching limited resources.
How does it work?
You harvest whatever small amount of autograft the patient has left. You mesh it widely, cutting a geometric pattern into it so it expands massively, perhaps covering 4 times its original area.
But stretching it that far creates these large, open, diamond-shaped gaps of raw wound.
Exactly. So you place this widely meshed autograft down as the inner layer, the bottom of the sandwich, and then you completely cover it with an outer layer of finely meshed cadaveric allograft.
So the cadaver skin acts as a biological shield. It protects those open spaces from infection and fluid loss, while the patient's own skin slowly heals underneath.
Yes. And as the autograft epithelializes and completely covers the wound bed, it naturally undercuts and sheds the cadaver skin on top.
It just pushes it off.
Yep. It is an incredibly elegant solution when you need to close a massive wound, but have very little donor skin.
Which brings us to the synthetic temporary dressings, like BioBrain, which is a bolaminate dressing, a silicone film with a nylon fabric mesh and porcine dermal collagen bound to it. Blood and fibrin clot within that nylon matrix to stick it to the wound.
Right.
But Transcyte is where this feels like pure science fiction to me. It is a polymer membrane seeded with neonatal human fibroblast cells. But the product is frozen, which completely kills the fibroblast before it is ever applied.
Dead cells.
Yeah. If the cells are dead, how does it provide any biological benefit? To me, it sounds like moving into a fully furnished house. Like the previous builders, the killed fibroblasts are gone, but they've left the structural scaffolding, the furniture, and the tools perfectly laid out for the patient's own body to use.
That's brilliant. And to take your furnished house analogy a step further, it's not just that the furniture is there, the heat is left on, and the fridge is fully stocked.
Huh. Okay, how so?
All those fibroblasts were alive and proliferating on the nylon mesh in the lab. They actively secreted human dermal collagen, matrix proteins, and vital growth
They
factors.
were building the environment.
Exactly. When the product is frozen, the cells die. But that highly complex 3D architectural matrix and those bound growth factors remain perfectly intact. So the patient's body doesn't have to waste vital energy rebuilding that entire extracellular matrix from scratch.
They just move right in. And what is the ultimate physiological goal of sealing the wound with these furnished matrices? Why is temporary closure so critical?
Because an open burn wound is essentially a massive radiator leaking fluid and heat. By firmly sealing the wound from the environment, you stop massive evaporative fluid loss.
And you stop profound heat loss.
Right. By shutting down those two physiological drains, you bring the patient's raging hypermetabolic engine back down to a manageable blitz line while they await permanent closure.
But eventually, the lease is up on that furnished house. We need permanent closure.
We do.
To finally heal the patient, you have to use the absolute limits of modern bioengineering and surgical geometry.
Okay.
Because autografts are the definitive answer. We use unmeshed sheet grafts for cosmetically sensitive areas like the face and hands because they don't leave a pattern.
Right.
But for everything else, we mesh it. And the meshing ratios go from 1.5 to 1 all the way up to an extreme 6 to 1 expansion ratio.
Which is huge. Meshing allows you to cover a vastly greater wound surface area from a very small donor site.
Right.
It also serves a critical mechanical function. The holes allow bleeding and exudate to escape from under the graft, rather than forming a hematoma that would physically lift the graft off the wound bed and cause it to die.
But a 6 to 1 mesh. The sheer mechanical difficulty of handling that sounds like a nightmare. It sounds like the extreme frustration of trying to apply a flimsy screen protector on a phone, making sure it's perfectly flat without tangling, but with actual life or death consequences.
It is exactly like that. But imagine the screen protector is made of wet tissue paper, and if you place it upside down, the tissue dies.
Oh my God.
Ensuring a 6 to 1 meshed graft is placed with the dermal side facing the wound bed without it curling onto itself requires immense technical skill. And the cosmetic trade-off is severe.
How does it look?
Once healed, meshed grafts leave a distinct permanent honeycomb or Venetian blind appearance on the skin.
Yeah, that makes sense. When autografts just aren't enough, we enter the realm of permanent skin substitutes. Integra, for example, is a bilaminar template. The outer layer is temporary silicone to act as the epidermis, but the inner layer is made of bovine tendon collagen and shark cartilage glycosaminoglycan. Shark cartilage.
The use of shark cartilage is brilliant. It acts as a highly structured extracellular matrix. It acts as a scaffold that organizes the patient's own migrating fibroblasts and endothelial cells, prompting them to regenerate a brand new neodermis.
So the body uses the shark cartilage to build its own skin layer.
Yes. That shark cartilage matrix becomes a permanent vascularized part of the patient. After about 21 days, once that neodermis is fully built, you peel off the outer silicone layer and replace it with an ultra-thin, split-thickness autograft.
And that's better than just a thin skin graft.
Oh, vastly. It provides much superior skin pliability and durability compared to placing a thin skin graft directly onto fat or fascia.
There's also matriderm, which is a single layer of bovine collagen and elastin that is applied simultaneously with a skin graft, though my understanding is it's generally less suitable for massive acute burns. But the most mind-bending permanent closure has to be cultured epithelial autograft, or CEA. Using tissue culture techniques, scientists can grow massive sheets of keratinocytes from a tiny postage stamp-sized patch of the patient's own skin.
It takes about 3 weeks to fabricate a sheet of CEA in the lab, but historically there has been a major functional problem with this.
What is it?
If you place cultured keratinocytes directly onto a fascial wound bed, they function terribly. They have very poor mechanical durability and develop severe scar contracture.
Why does that happen?
Because they entirely lack a dermal foundation. They are just the roof of the house without the walls.
Which brings us to the Quono technique. How does this technique solve the missing dermal foundation?
The Quono technique is kind of a biological hack, if you will. First, you use a thick cadaveric allograft to temporarily close the excised wound.
Okay.
You wait until that cadaver skin has fully revascularized on the patient. Then you take the patient back to the operating theater and use dermabrasion to physically grind away the epidermis of the cadaver skin.
leaving only the thick vascularized cadaveric dermis behind.
Exactly.
And then you place the patient's laboratory-grown CEA cells directly on top of that donor dermis. But wait, why doesn't the patient's immune system violently reject the donor's dermis?
Because graft rejection isn't triggered equally by all layers of the skin.
Really?
The potent immune response is primarily mediated by specific antigen-presenting cells called Langerhans cells, which reside almost exclusively in the epidermis.
Oh, so by mechanically stripping away the epidermis of the cadaver graft.
You are physically removing the primary triggers for immune rejection. You trick the body. You keep the structural vascularized dermis as a functional home for the cultured cells without triggering a massive immune cascade.
Wow. We've covered an immense amount of ground today for your exam prep. From understanding why early excision blunts the hypermetabolic engine to the precise visual cues and bleeding paradoxes of tangential excision, right through to the physiological mechanisms of trial eye, temporary synthetics, and shark cartilage matrices. This just highlights the incredible adaptability of human physiology when paired with surgical ingenuity.
It really does. And as a final thought to mull over, the corner technique proves that we can successfully trick the immune system by keeping a donor's dermis and merely replacing the epidermis to avoid those Langerhans cells.
Right.
As biological 3D printing technology advances rapidly, how close are we to a future where we bypass cadaveric donors and shark cartilage entirely?
That would be amazing.
Imagine a surgical theater where we can simply 3D print a fully vascularized, rejection-proof dermal matrix, custom-made and on-demand for any massive trauma patient.
That is a wild and very real frontier to leave off on. We want to hear your thoughts on these bioengineering feats or any specific questions you have about burn physiology, so please leave a comment down below.
Yeah, let us know what you think.
If you found this breakdown useful for your clinical knowledge or board prep, press follow on the show to listen to more deep dives, and be sure to rate it. Also, get a premium subscription to listen to our highly focused journal club and clinical cases deep dives. Thank you for diving deep with us today.